Hello, I'm John Sweetenham, the Associate Director for Clinical Affairs at UT Southwestern's Harold C. Simmons Comprehensive Cancer Center and host of the ASCO Daily News podcast. I'm delighted to welcome my friend and colleague, Dr. Neeraj Agarwal, the Director of the Genitourinary Cancers Program and a Professor of Medicine at the University of Utah's Huntsman Cancer Institute. Dr. Agarwal also serves as Editor-in-Chief of the ASCO Daily News. Today, he'll be sharing his insights on compelling studies that will be featured at the 2022 ASCO annual meeting, addressing access to clinical trials, disparities associated with high-deductible health plans, rising drug costs, and more. Our full disclosures are available in the show notes, and disclosures of all guests on the podcast can be found on our transcripts at asco.org/podcasts. Neeraj, it's great to have you back on the podcast.
Thanks, John.
Neeraj, let's begin with abstract 6503. This study looks at the impact of high-deductible health plans on delays in metastatic cancer diagnosis. What do you think about this study, and why should it be on our radar?
Well, John, in high-deductible health plans, patients are liable for the cost of all cancer-related care, with the exception of screening tests, until their annual deductible is met. Due to increased out-of-pocket cost, patients may postpone seeing a physician for concerning symptoms or diagnostic testing, leading to delayed diagnosis. So in this study, Dr. Nicholas Trad and Frank Wareham assessed the impact of high-deductible health plans on the timing of metastatic cancer detection. The authors leveraged a nationally representative cohort of more than 340,000 privately insured members whose employers mandated a switch from a low deductible of less than $500 plan to a high deductible plan of more than $1,000. So the group consisted of more than 1 million individuals and contemporary time frame whose employers offered only low deductible plans. Participants were matched based on multiple baseline characteristics. Time to metastatic cancer diagnosis in the before and after switching to high deductible health plans was investigated using a weighted Cox proportional hazards model. After matching, there were no systematic differences between the two groups with regards to baseline characteristics, and there were no differences in time to metastatic cancer diagnosis prior to the switch to high deductible health plans. However, after the employer mandated switch to the high deductible health plans, these participants had lower odds of metastatic cancer diagnosis, which was significant statistically speaking and indicates of delayed detection of metastatic cancer diagnosis relative to the control group.
These are certainly concerning data, Neeraj. What's your key takeaway from this study?
So the key takeaway from the study is that compared with conventional health plans, high deductible health plans are associated with delayed detection of metastatic cancer, implying that patients postpone seeking care for concerning symptoms or even defer diagnostic testing when they are exposed to high cost sharing.
Thanks, Neeraj. So let's continue with this theme of the financial burden of cancer care for our patients. Of course, we're all aware of the rising costs of targeted oral therapies, and this was addressed in abstract 6504, where the study looks at the rising costs of targeted oral treatments among Medicare beneficiaries, and the study reported a substantial increase in the total cost and out-of-pocket costs of these medicines. Can you tell us more about this abstract?
Yes. So due to the rapidly rising cost of targeted oral anti-cancer medicines, Doctors Meng Li and Ya Chen Shi examined recent trends and the financial burden of these oral medicines among patients with cancer with Medicare Part D insurance. So eligible patients in the SEER Medicare database had to be 65 years and older and had to have one primary cancer diagnosed. The investigators estimated the trends in the share of patients who used targeted oral anti-cancer medicines, the percentage of users reaching catastrophic coverage, and the total and patients out-of-pocket spending on these medicines in the catastrophic phase in a year. So from 2011 to 2016, the uptake of these oral anti-cancer medicines increased from approximately 4% to 9%. The percentage of those who reached catastrophic coverage increased from 55% to 60%. Among those who reached the catastrophic phase, the mean total annual gross spending on oral anti-cancer medicine increased fourfolds from approximately $16,000 to $64,000. And the mean out-of-pocket spending for the patients rose from approximately $600 to $2,600.
Yes, this is more evidence that the financial toxicity generated from an increase in spending and out-of-pocket costs is going to have serious impacts for our patients. Would you agree with that, Neeraj?
Yes, John. The key takeaway from this study is that the financial burden of these oral anti-cancer medicines continue to increase. In the relative short period of time we see here of 5 years from 2011 to 2016, there was a fourfold increase in the total cost and out-of-pocket cost of these medicines. And in my view, these findings warrant immediate actions to rein in drug prices and capping out-of-pocket spending for our patients.
Absolutely. It's very difficult to know where this will end unless we see some kind of slowdown in these rising costs. I'm going to change gears just a little bit now to address the access to clinical trials, which is the subject of abstract number 6505. This study looked at the implementation of the Affordable Care Act Medicaid expansion, which was associated with an almost threefold increase in the proportion of patients using Medicaid in cancer clinical trials by early 2020. What are your thoughts on this study?
As you said, Affordable Care Act Medicaid expansion resulted in an increased use of this platform across the nation. However, its impact on access to clinical trials has not been examined. So, in this study, Drs. Joseph Unger and Drs. Don Hirschman examined the number and proportion of patients insured by Medicaid at enrollment over time using data from the SWOG Cancer Research Network. In addition, they also examined all patients 18 to 64-year-old enrolled in treatment trials between 1992 to 2020 using Medicaid versus private insurance. So the implementation of the Affordable Care Act Medicaid expansion was associated with nearly a threefold increase from 7% to 21% in the proportion of patients using Medicaid in cancer clinical trials by early 2020. The increase per year of Medicaid use for patients on these treatment trials from states that implemented the Affordable Care Act Medicaid expansion was 27% compared to 7% for patients from other states who did not implement this platform of Affordable Care Act Medicaid expansion. So the key takeaway from the study is that better access to clinical trials for more vulnerable patients is critical to improve confidence in how generalizable these trial findings are. In addition, these results suggest that the recently enacted Cancer Treatment Act may continue to improve access to clinical trials for those with Medicaid insurance or those who are vulnerable patients.
Yes, I think this is a really important study which adds to the growing literature on the benefits of the Affordable Care Act and Medicaid expansion on cancer care in general, in this case specifically related to clinical trials. So important, I think. And on that theme of equity, I think the next two abstracts we're going to discuss address specific aspects of equity, which I think are both interesting and really important. So, abstract number 6510 has interesting research which conveys an urgent need to ensure equitable patient reported access and implementation and to address greater reported symptom burden among minority patients. Why do you think this study is important?
Routine collection of patient reported outcomes for patients with cancer is an evidence based practice and critical component of high quality cancer care. But the real world adherence and reporting patterns are poorly understood. In this study, Drs. Samuel Tekvorian and Ravi Parikh examined differences in adherence to the collection of patient reported outcomes and reported symptoms by race and ethnicity. This was a retrospective cross sectional study using de identified electronic health record data from an NCI designated comprehensive cancer center. The participants included adults seen in follow up at one of the two medical oncology practices. One was in academic and one was in community from June 2019 to February 2020. Using ordinary least squares regression, the authors modeled patient adherence as a function of race or ethnicity, and this was adjusted for age, sex, insurance, median area income, ECOG performance status, and many other patient related characteristics. Results show that adjusted mean PRO adherence and reported symptoms varied by race and ethnicity, with Black and Hispanic patients being less likely to complete PRO questionnaires, but reporting significantly higher symptom burden compared to the white patients.
Right, so it seems that more work is needed to ensure equitable access and adherence to PRO questionnaires so we can better address the symptom burden of our minority patients.
Correct, John. In this large cohort reflecting real world PRO collection patterns, Black and Hispanic patients were less likely than white patients to complete these PRO questionnaires, but more likely to report more severe symptoms. And I think there is an urgent need to ensure equitable PRO access and implementation and to address greater reported symptom burden among minority patients.
Let's continue the theme of health equity and cancer care equity into the use of telemedicine. Of course, we saw a massive expansion of telemedicine for cancer patients during the COVID-19 pandemic, but studies are emerging now to show that there have been substantial disparities among the Black, uninsured, non-urban, and less affluent patients who are less likely to use telemedicine services. Abstract 6511 reminds us that telemedicine may expand access to specialty care, but the proliferation of these services may widen cancer care disparities if vulnerable populations don't have equitable access. Can you tell us more about this abstract?
These are indeed very interesting findings, John. The COVID 19 pandemic was associated with declines in person clinical visits, with a concurrent increase in the use of telemedicine. In this study, Dr. Jenny Guadamuz and Gregory Calip assessed demographic and socioeconomic factors associated with telemedicine use among patients initiating treatment for 21 common cancers at community oncology clinics. This was a retrospective study and made use of the nationwide Flatiron electronic health record derived de identified database of patients with cancer. The authors focused on differences in telemedicine use across race and ethnicity, insurance coverage, rural versus urban areas, and socioeconomic status. They used logistic regression models for this analysis, which was adjusted for clinical characteristics to examine differences in telemedicine use among these different cohorts. Results indicate Black patients were significantly less likely to use telemedicine services compared to white patients. Telemedicine use was also significantly lower among patients without documented insurance than well insured patients. It was also lower in patients from rural and suburban areas versus patients who were living in urban areas. And lastly, telemedicine use was significantly lower in patients in the least affluent areas than those in the most affluent areas. So during the COVID-19 pandemic, nearly 1/5 of patients initiating cancer treatment using telemedicine services, among these patients, we see substantial disparities. So Black, uninsured, non-urban, and less affluent patients were less likely to use telemedicine services. So the take-home message from this study is that while telemedicine may expand access to care, the proliferation of these services may actually widen cancer care disparities if vulnerable population do not have equitable access to these services.
Thanks, Neeraj. So the final study that we'll discuss today also looks at another aspect of disparities, and that's abstract number 6517. It's a case-controlled study of healthcare disparities in sex and gender minority patients with breast cancer. What are the key takeaways from this study?
Disparities in the quality of diagnosis and treatment of breast cancer in sex and gender minority populations are largely undefined. Only 24% of studies funded by National Cancer Institute capture data on sexual orientation, and only 10% capture data on gender identity. In this case control study, Doctors Eric Eckert and Alison Kurian matched sex and gender minority patients with breast cancer to cisgender heterosexual controls in the Stanford University Healthcare Database. 92 sex and gender minority patients were identified, who were then matched by year of diagnosis, age, stage of cancer, presence of ER and HER2 new receptor status to cisgender heterosexual controls within this database. Additional data on demographics, diagnosis, treatment, and relapse were then manually abstracted from the electronic health care records. The sex and gender minority cohort was comprised of 80% lesbian, 13% bisexuals, and 6% transgender men. One of the most pertinent findings was the significant, almost twice as much delay in time to diagnosis from the onset of symptom in these minority patients versus control. Although there was no difference in the receipt of surgery, post-surgical radiation, or neoadjuvant therapy, sex and gender minority patients were significantly less likely to undergo chest reconstruction surgery, and if they were estrogen receptor positive, they were significantly less likely to complete at least 5 years of ER-directed therapy. Please also note that sex and gender minority patients used more alternative medicine, had a higher rate of documented refusal of recommended oncologic treatments, and they experienced a higher recurrence rates. So the key takeaway from this study is that this is a first study. I really want to congratulate the investigators who examined quality of diagnosis and treatment of breast cancer in sex and gender minority patients. Several novel potential healthcare disparities are identified in these patients, which should be further evaluated in population-based studies to inform further interventions.
Neeraj, always a pleasure to talk with you and have an opportunity to spend some time with you. So thanks very much for sharing your insights on these compelling studies today. Our listeners will find the links to these abstracts in the transcripts of this episode.
Thanks, John.
And thanks to our listeners for your time today. If you're enjoying the content on the ASCO Daily News podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.